started. I want to welcome you all to our second year debut kickoff event tonight for Smilow Shares with Primary Care. It's been Karen Brown and I have been working on this for the past year, and it's been amazing to see that there have been I think around 2,000 hits across the globe. And as well as about 250 some participants who've joined us throughout the years. So we are getting going with a topic I think that is really near and dear to everyone's heart around genetic testing, and something we're really highlighting that the aspects of that primary care physicians face. And for those of you who have attended before, and I recognize many of you, this will be old hat to you, but for those that it's your first time, it's really a monthly lecture series that focuses on primary care perspectives on cancer and hematology. And you are the audience, primary care clinicians, and we constructed it in a way where primary care is a panelist and really helps to work with Smilow specialists to figure out what's going to be the most interesting and important for you to know. We changed it's this year. It's at 5:30, hoping to get a few more folks at the end of the day. And you know, there are just so many venues where you can get information about cancer, but again, this is the venue that's focused on primary care, and as such, a case-based discussion. Okay, next slide, please. I have the honor tonight to do the introductions, and I can introduce Karen Brown. Dr. Brown is an experienced general internist who completed her internal medicine residency and chief residency at Yale. She cares for patients through NEMG at the Divine campus in North Haven. And she's been a medical director for the YNHH Primary Care Center, Community Medical Group, NEMG New Haven region, and now the medical director of primary care for NEMG, where there are 50 offices over 3 states and 210 PCPs. She's also vice chief of community affairs for the YM section of general internal medicine, and she's been part of the Yale New Haven Hospital System ambulatory clinical quality councils in lots of different work groups and committees over the past 30 years. This is an interesting fact. Dr. Brown had a fellowship in HEMONC lined up after residency, and then she really found her passion in primary care during her year as ambulatory chief medical resident. And her passion is for creating systems of person-centered, trustworthy care through inclusive and innovative leadership. And I think that really describes to the T the kind of leader she is. So thank you, Karen, for joining us tonight. Veda Giri is Dr. Giri is a medical oncologist with specialization in clinical cancer genetics. She is our division chief of clinical cancer genetics for Yale School of Medicine. She's a director of our cancer genetics and prevention program and the director of the early onset cancer program at Yale Cancer Center. She received her medical degree from Sidney Kimmel Medical College and proceeded to complete her residency internal medicine fellowship in HEMONC at the University of Michigan, and then completed advanced training in molecular cancer genetics and cancer risk assessment at Fox Chase, and also has a certification from City of Hope Comprehensive Cancer Center. She serves on multiple national committees, including the NCCN Network, NIH, ASCO, as well as our leader of cancer genetics and prevention at Yale. She leads a comprehensive effort in genetic evaluation for precision medicine, tailored cancer screening, and hereditary cancer assessment across patient populations. She's PI in multiple grant-funded studies, and as the director of the early onset cancer program, and hopefully she'll talk about that tonight too, she is leading a really cutting-edge translational effort to address the clinical research and the psychosocial needs of patients with early onset cancers. And that's a really integral part to that effort is underserved and minority patients with early onset cancers. Thank you for joining us. And then finally, last but not least, Claire Healy, who is one of the co-manager genetic counselors for the Smilow Cancer Genetics and Prevention Program. She graduated from the genetic counseling program at the University of North Carolina at Greensboro, and previously worked as a genetic counselor at the Dana-Farber Cancer Institute until she joined us in 2015. She provides outreach coordination for cancer genetics at L&M and St. Francis, as well as seeing patients at Smilow Cancer Hospital in Waterford. And patients just love her. So thank you, all of you three, for joining us tonight. We have a powerhouse of women. We decided to go with first names as we're talking to each other, but there's just a lot of training, a lot of impressive credentials here as well. So I'm going to turn it over to Karen to start the cases.
Great. So thank you, Anne, for the introduction, and thank you, everybody, for joining. What a revolution and change that we're having in primary care with better access to genetic testing. We're at the beginning of the journey. I think our oncology colleagues are a little ahead. And it's really nice to get kind of advice from somebody who does genetic testing, somebody who works with results of it. And there's so many lessons here. So I will dive into some cases because we always seem to learn best from case-based learning. So these are real patients. Slight details may have been modified. I recently saw a 48-year-old for a preventive visit. And, you know, we kind of, as we went through the visit, we reminisced that she had been diagnosed with infiltrating ductal and lobular carcinoma of the breast at age 38 after detecting a lump. And she, actually, let me just move my screen, in 2013. And so this was a stage 1A, T1A, no nodes of the right side of the breast. And she had a bilateral mastectomy. And you know, that was not necessary, obviously, to treat the lump, but it was done as prevention for contralateral breast cancer and was treated with tamoxifen. So she was definitely an early onset cancer. And as such, I had, you know, that was always on my mind when I saw her. Her big news today was that her sister had been diagnosed with ovarian cancer at the age of 42. And there was already an extensive family history of cancer. Her paternal aunt was diagnosed with breast cancer at age 47. Her paternal grandmother also had breast cancer, unclear if this was post or premenopausal. And her paternal uncle had prostate and pancreatic cancer. And, you know, she said to me, there's just got to be something. You know, we all tested. And we had negative testing for genetic cancer. Our BRCAs were all negative, you know, and so her kind of additional family history prompted her to dwell on this a little more as we went through our visit. So before we kind of go into her current question of, you know, what more should we do now, I just wanted to really lay out some of what we might see in this patient's personal and family history that would suggest a hereditary cancer syndrome, and also, you know, sometimes it's not quite this obvious as somebody saying, I know it's in my family, but what else should we be looking for? So Veda, I'm going to pass that to you.
Yes, absolutely. Great question. And again, it's such a pleasure to be here. Thank you so much. And look forward to meeting many of you here as time goes by. For this case, you know, there are definitely some striking features that raise the suspicion for a hereditary cancer syndrome. One of which is that the patient herself was diagnosed with breast cancer at a young age, at 38, which is one of the biggest red flags for thinking about genetic testing and consideration for hereditary cancer syndrome. We also see a very strong family history with a clustering of specific cancers. So, of course, her sister having had ovarian cancer at age 42. And very importantly, to think about both sides of the family when thinking of family history. This is a female, and making sure that not only is the maternal side of the family history captured, but also the paternal side of the family history. And here we see a very strong paternal family history of breast cancer at the age of 47. The grandmother also diagnosed with breast cancer. Now, age is unknown, so it's mostly just part of the clustering. And then thinking of additional cancers that might be joined together in terms of a genetic link or hereditary cancer syndrome. And we see that with that paternal uncle with prostate cancer and pancreatic cancer. So we have strong indications both from the personal history of early onset breast cancer and then this clustering as far as family history.
So if she and her family all tested negative, Claire, what's the role of repeating genetic testing, at this interval or a different interval?
Yeah, so with most disciplines in medicine, genetic testing really improves all the time, and our understanding of hereditary cancer syndromes is always changing as well. So I thought it would be helpful to kind of put a timeline together just so that we can kind of put into context how genetic testing changes over time. So in 1994, the BRCA1 gene was identified, and in 1995, the BRCA2 gene was identified. And then shortly thereafter, in 1996, clinical genetic testing of those two genes became available. That was done through Sanger sequencing. And then it wasn't until 2002 that there was an identification of the fact that there were actually within BRCA1 some common rearrangements of that gene that were missed through sequencing. And so there became a new iteration of BRCA testing at that point that sequenced BRCA1 and BRCA2 and included those 5 rearrangements of BRCA1. And then about 4 years later, there was the identification of the fact that actually there are deletions and duplications elsewhere in BRCA1 as well and within BRCA2. So the next iteration of testing became available, but really not available to all patients who were undergoing genetic testing of BRCA1 and BRCA2 until 2012. That in that intervening 6 years, some patients qualified for that comprehensive deletion duplication analysis, and then other patients didn't. So it wasn't until 2012 that patients who were receiving BRCA testing would have uniformly received that comprehensive deletion duplication testing. And then shortly thereafter, in 2013, multi-gene panel testing really became available. And so these multi-gene panels allow us to look at multiple genes all at once through next generation sequencing. So an update to the testing technology and the inclusion of different genes. And with these multi-gene panels, laboratories will often add genes when there's sort of emerging data that there's some cancer risk associated with the gene mutations. Then over time, they may remove genes because they learn actually those aren't associated with hereditary cancer risk. We might learn of new genes that then get put onto these larger panels. So these multi-gene panels are constantly evolving. And so that's ongoing. And so I would say that for patients who have had genetic testing 5 to 10 years ago, there are likely updates to genetic testing that are available to them. So when we meet with patients and we're thinking about genetic test options for them, we always sort of present options to the patient and think about testing as sort of starting very narrowed and focused, and then we're bringing that open to more genes and more genes. So maybe we know there's a mutation in the family already. There's really nothing else that stands out to us as being concerning for hereditary risk. And so we take a very narrowed, focused approach and we just do a targeted mutation test for a patient. Or maybe the patient's history is so striking that we can say with a lot of confidence it must be a mutation in this particular gene, if it's anything. And so we'll do, single gene or maybe 1 or 2 genes. but maybe the history is broad enough that it could be really representative of a lot of different genes, in which case we might say, let's take a more kind of cancer-focused approach to the test. We'll do a panel of genes, but maybe all of those genes are just associated with hereditary breast cancer, for example. And then we can go even broader than that and say, let's look at genes that aren't just associated with hereditary breast cancer. Maybe there's some colon cancer in the family, or maybe the patient is really just motivated for as much information as they can get as possible from their test. And then we might really take a broad approach to genetic testing, look anywhere from 47 to 84 genes in that patient's genetic test, and really across multiple different phenotypes. And one of the things that I think is important, and one of the things that we share with patients, is that with that multi-gene panel approach to testing, we are more likely to identify a mutation. So we're increasing our diagnostic yield the more genes we add, but we are simultaneously increasing the likelihood of identifying a variant of uncertain significance. And a variant of uncertain significance is frustrating for patients and providers because it's just a finding in a gene for which the laboratory has limited information. It's rare, hasn't been seen enough to be characterized well to know if that is actually a true mutation in the gene, or is it a benign variation in the DNA code, not increasing the risk for any type of disease. And so patients need to be aware that, yes, we're increasing diagnostic yield, but we're simultaneously increasing the likelihood of this sort of inconclusive result. And the more genes we look at, the higher the likelihood that we could identify a mutation in something that we really weren't expecting based on the patient's phenotype. So maybe we're expecting something hereditary breast cancer focused for a patient, but the patient wanted a broad panel. And it turns out that there's a mutation in a hereditary kidney cancer gene. That might be very surprising for the patient, and patients need to be aware that that's a possibility so that they can be comfortable with that type of result should it occur. So for this patient who had prior negative BRCA1 and BRCA2 testing at the time of her breast cancer diagnosis 10 years ago, there are definitely updates to genetic testing that could be performed. And so this patient could have opted for a multi-gene panel, and in fact was found to have a PALB2 mutation. And I'll turn it over to Dr. Giri to kind of contextualize what that means.
Yes, absolutely. And I think this highlights the nature of where going from such focused testing from BRCA1 and 2 to multi-gene panel testing can identify a mutation pathogenic variant in those other genes that we can test. And so PALB2 is one of those genes that is now pretty standard in terms of breast cancer genetic testing. And classically, it has been known to be associated for many years with female breast cancer as well as pancreatic cancer. And then there's been more data for association also now over the recent years with ovarian cancer and even with potentially male breast cancer. And so the NCCN guidelines actually address ways to sort of mitigate this risk or have risk-based screening for individuals who carry PALB2 mutations. And so for females with a PALB2 mutation, that sort of absolute risk for breast cancer is about 41 to 60%, based on the studies and the cohorts that have been studied. And so the NCCN recommends that screening begin for carriers at age 30, and that includes mammogram plus breast MRI. And there can be a discussion of risk-reducing mastectomy, but again, that needs to be a careful discussion with the breast surgeon as well. For males, there is now even incorporation of male breast cancer sort of management or screening. Now, most of that male breast cancer management falls in when a male has a BRCA2 mutation, where clinical breast exams start at the age of 35. That's quite different than anything that's ever recommended in the general population, which it's not because it's such a rare cancer. And so there can be a consideration to follow the same type of approach for a male who has a PALB2 mutation. And PALB2 is closely linked molecularly with BRCA2, so kind of makes mechanistic sense as well. There's also ovarian cancer recommendations in terms of risk reduction. So the absolute risk for ovarian cancer has been estimated around 3 to 5%. And so the NCCN states to consider risk reducing salpingo oophorectomy at ages around 45 to 50 for females. And then for the pancreatic cancer management, it really still is really important to look at whether there's a family history of pancreatic cancer, which really, especially in a first degree relative, to really increase the sort of, to compel individuals to go ahead and meet with a high risk gastroenterologist and discuss the pancreatic screening, which can be, invasive with imaging, but quite, important to discuss the risks and benefits of that. We actually have, a very strong high-risk team at Yale and Smilow. And so for individuals who are highly motivated with a PALB2 mutation and who may not have even a strong family history, we often give them the option to see a high-risk gastroenterologist as well to, again, discuss those pros and cons of pancreatic cancer screening. So a lot of sort of recommendations that are, coming forth out of this recognition of this mutation in PALB2.
That's really helpful. Let me, before we move to the next case with Jill Banatowski, excellently queued up from a question she typed into the chat. Maybe if you could just comment on whether the screening for pancreatic cancer, what is the state of that as showing evidence that it's helpful in these high-risk individuals?
Mm-hmm. So there's still a lot of work going on, for example, with the CAPS-5 study, et cetera, that Dr. James Farrell is leading at Smilow. But most of the evidence for benefit is in individuals who carry BRCA mutations and those that have a strong family history. So the guidelines were very focused, and they sort of still are in terms of really thinking of that recommendation more strongly to see a high-risk gastroenterologist for folks that are in those who have that clinical scenario. It's expanding, though, too, to think about those patients that have, as I mentioned, PALB2 mutations, Lynch syndrome carriers as well. So there are these ATM is another gene to consider this. So there's a host of other genes to think about this, particularly if there's a family history of pancreatic cancer for that risk-benefit discussion.
That's terrific. And I know for this patient, having a counselor having gone through this and counseled, I got that sort of information directly at the end of the consult note. And that was super helpful to me to know what to look for, because this is, BRCA is very common, in really even lay people's vocabulary now, but the PALB2 is not yet as understood or recognized.
Yes.
Okay,
yes.
Let's move to the next case.
If I could just say one more thing just before we move ahead, is this also now gives us information for hereditary cancer risk in the family. So this cascade testing concept really becomes critical to ensure that blood relatives are getting testing for this mutation, because as you know, some of those, like the breast cancer screening, is starting at a younger age. And so ensuring that appropriate screening is being done based on whether or not a person has a mutation in the family.
Perfect. Thank you. Okay, so this is another woman who came, she has 2 children at home, and she presented for a routine preventive visit. There was really nothing on her exam. It was the discussion that we had about her family history that prompts her to be included in the talk. So she gave me this information, which not to go on a tangent, but man, is it important to fill this out in family history. You can type it in your note. But I happen to know for a fact from some work that Claire and I did earlier that family history is a discrete data and epic. And we are now and will in the future be pulling that information to help with, decision support. Have you considered, for patients? So yes, I swear I typed this all very carefully into the family history. And so what she told me is that her mother had sequential breast cancer. First on one side and then the other, first at the age of 42 early, and second at age 53. Her maternal aunt was diagnosed with ovarian cancer. And she had a first cousin who was the daughter of the same aunt who had also early onset breast cancer at the age of 36. And so, interestingly, and, family dynamics are always interesting. There were no results of genetic testing from any of these affected family members, which is usually the secret when you actually ask. But, she wasn't aware that anybody had been tested. And so she did a direct-to-consumer test, 23andMe or something, after she saw an advertisement on social media and reported that the test had been negative. So she hadn't really started mammograms yet or really thought about it much until we were discussing this family history. So, I mean, the first question, again, always to get back to is, what is it about this? And what are some examples of kind of clusters that might suggest the need for early screening? Is there anything additional that we would say in this one, Veda, that would be another kind of cluster recognition?
Yes, right. So definitely what we see here from a clustering of cancers perspective is that we have this, strong maternal family history of the mother having had not only breast cancer, but bilateral breast cancer, also at a young age, aunt with ovarian cancer, and then also a young breast cancer in a first cousin. So we see this clustering of breast and ovarian cancers, which can be concerning for hereditary breast and ovarian cancer syndrome, classically linked with BRCA1 and 2, but as we've just discussed, it could be many other genes that we would be testing for now with updated genetic testing. Also in that clustering, could be additional cancers that actually could also be connected with hereditary breast and ovarian cancer, like pancreatic cancer, prostate cancer, and melanoma. So these could all be genetically linked with BRCA or additional genes that can be connected. We also see other clusterings, and just to bring forth another really important hereditary cancer syndrome being Lynch syndrome. And for this particular syndrome, there's clustering of actually a host of other cancers, such as colorectal cancer, pancreatic cancer, ovarian and uterine cancers, upper GI cancers, urothelial cancers. So it actually really points to the need to take a broad family history, again, across both maternal, paternal lineages, and as far out as possible, because it is really informative to think about, what are the genes that we should be including in genetic testing.
Okay. And then I think, Claire, you're going to go over what we actually did find on the results and try to explain this mystery of her negative test to help us sort out the role of the direct-to-consumer testing.
Yeah, so this patient was referred and we did meet with her and order genetic testing for her, and she did come back with a BRCA1 pathogenic mutation. She also had a variant of unknown significance, which you can see there as well. So I think, patients are really aware of their options for genetic testing, and there are big social media pushes for direct-to-consumer genetic testing. And I think one of the keys takeaway messages here is that direct-to-consumer genetic testing really does not have the same depth of coverage as clinical genetic testing. And so this patient reported that she had had negative BRCA testing, but her direct-to-consumer genetic test actually did not include full sequencing and deletion duplication analysis of the BRCA1 and BRCA2 genes. The commercial available direct-to-consumer tests for BRCA1 and BRCA2 through most companies that are doing direct-to-consumer testing right now really only looks for about 35 variants within those genes. So it's not the same level of coverage. And so this patient's mutation was missed because it wasn't one of the variants that they were looking for in that direct-to-consumer test. So I do want to just talk a little bit about direct-to-consumer genetic testing. There was a paper that came out in Genetics and Medicine a while ago now, back in 2018, that looked at results of direct-to-consumer genetic testing and then clinically confirming those results. So just like if we see a patient who's had direct-to-consumer genetic testing and reports that they're negative, we want to clinically confirm that that's true. The same is true if a patient reports that they have a pathogenic variant. Even if they bring you a test report that says, yes, this patient has a mutation, this paper tells us it's really important to clinically confirm those results, because what they found was that actually about 60% of the time you will clinically confirm that those results were accurate, but 40% of the time you'll confirm that that was actually a false positive. And you can see in this chart here that some of those results that were not confirmed through clinical genetic testing were in genes like BRCA1 and BRCA2, Lynch syndrome, that MLH1 gene, where there are actually recommendations for prophylactic surgery to help reduce cancer risk. And so this is really important to make sure that while patients certainly have access to direct-to-consumer genetic testing, and we want to support them in making decisions that feel right for their healthcare, it's our responsibility as clinicians to make sure that we follow that up with a clinically appropriate test as well.
That is incredibly helpful and also dismaying. So if the patient were to be diagnosed with breast cancer, and we knew, that she had this predisposition, Veda, talk to us about unique considerations for these women with early onset breast cancer or people with other early onset cancers that are often genetic. How can we support them?
Absolutely. It's such an important population to, like you said, support and think about in a very unique way. So, these patients, for example, for herself, if she was diagnosed with breast cancer, depending on the stage and the aggressiveness of the breast cancer, could be recommended to have surgery, potentially followed by chemotherapy or maybe not, radiation therapy, and then longer term hormonal therapy, again, depending on marker status and things like that. And, as well as addressing additional cancer risks for a person, who has a BRCA1 mutation, such as ovarian, radical, the prophylactic salpingo oophorectomy, and let alone the potential of, impact on ovarian function if she were to go through, say, chemotherapy or other things. So these individuals, they have a lot of clinical needs and psychosocial needs that are really important in the early onset space. So one of the key programs that we are developing at Yale Cancer Center and Smilow Cancer Hospital is the Early Onset Cancer Program. And one of our first initiatives is in the space of breast cancer to think about ways to support these patients. So we recognize that these patients have very unique psychosocial needs. They're dealing not only with a breast cancer diagnosis and treatment, but also impacts, as I mentioned, such as fertility preservation and can they have more children? They're often feeling very isolated and alone from their friends and their peers. They're at a very busy time in their lives with either young kids or working. And so there's a lot on their plate in terms of thinking of responsibilities and also taking care of themselves. Many of them have, mental illness exacerbations, and, on top of that is the issues that can arise from minority underserved populations that are really struggling with access to care and, their needs. And so the program is actually developing a navigator program to help these patients through their initial diagnosis all the way through their treatment and into survivorship. So what we hope to do is have the navigator really be that support person for them and link them with the important services and really help them through the course of their treatment and beyond.
That's terrific. Thanks. So we're equal opportunity here, or at least one out of the three cases. We'll get to a man. And again, this was a patient who I saw the same week I was preparing this. And, at the age of 40, he was healthy and health conscious. He was of Ashkenazi Jewish descent with a family history that suggested BRCA. Maternal and paternal grandmothers had breast cancer. His maternal aunt had breast and ovarian cancer, and his maternal cousin had pancreatic cancer and reportedly did test positive for BRCA2. So, I mean, does the fact that we have a family member who has a reported genetic test positivity influence further testing, what we would order or how we would proceed, and does it have any other impact on this patient?
So for this patient, the fact that there's a BRCA2 mutation reported in his cousin would give us an indication that our patient has at least a 12.5% chance to possibly share that same mutation. And the family history on that side is consistent with a BRCA2 mutation, right? We have breast cancer, early onset cancers, and the aunt having had both breast and ovarian cancer really is suspicious. And so that would tell us that really we're sort of thinking that the cancers in the family are really linked to that BRCA2 mutation. And so if I were to approach genetic testing for this individual, if I had a copy of the patient's test report and could kind of confirm exactly what mutation I was looking for, I might be inclined just to order single site testing of that mutation for the patient. I also don't think there's anything wrong with ordering BRCA1 and BRCA2, especially if you didn't have a copy of the cousin's test report. But I don't know that it would be necessary to do a large gene panel unless there was something on the paternal side of the family that just wasn't reported here that was kind of standing out to me as being concerning for something hereditary as well.
Good. Okay. And then I guess, the next question, and Veda, this is partly for discussion and partly for you. Are there other steps that a primary care provider should take after meeting with this patient? Assuming that the test, is likely to be positive, genetic counseling is helpful, I think, especially when you really do think something's going to be positive. What else do you think we need to do with this?
Yes, I think it goes also to the NCCN guidelines about genetic testing, recognizing that the breast, ovarian, and pancreatic guideline applies to males as well. And so the guidelines are pretty complex. And so we always try to distill them down as much as possible for various different providers, whether it's in oncology, to kind of keep it to the scope of their care. But, we do see here that, the guidelines state for individuals diagnosed with a young breast cancer, age less than or equal to 50, combination of cancers in the family, like breast, ovarian, pancreatic, prostate cancer, multiple relatives that have been affected with these cancers. And recognizing that, intake of ancestry can be really important here. So knowing that this person was of Ashkenazi Jewish ancestry, I think these are all really important for any provider to really think about sort of gathering in a systematic way. Certainly knowing that there was a BRCA2 mutation in the family is another key piece of information to refer for genetic counseling and genetic testing. So I think it goes more to thinking about, strong family history collection and asking about the genetic mutation status, in the family, along with ancestry information. And so again, in this case too, it's thinking about, this is a male and those cancers were on the maternal side of the family. So it just points to, again, that broader family history intake.
Yeah. And I mean, again, just in full disclosure that he was 10 years ago, and there's been a lot that's developed with this gentleman. And really a lot of things that were predicted by his genetic testing results, I did over time find to come true. But I thought it was a really good launching, space to kind of launch a conversation about what would a genetics evaluation have looked like for him, like what happens when you send somebody for that, and also how do we make sure that that information is accessible? Like, what if he changed primary care clinicians, or what if he lost a follow-up and came back? How do we make sure that the results of genetic testing are located in a place that future clinicians will be aware of risk as we go through. So, Claire, this is all yours.
All right. So I think Dr. Giri and I are going to kind of go back and forth together and talk about ways that we can partner together as both a genetics program and primary care providers to care for the patients. And so one option that is available is what we call our point of care, although Karen pointed out that maybe you would call this something different in your clinic. And our point of care model really is trying to empower providers to feel like they can take on some of this genetic testing themselves. And so if providers are interested in partnering with us in this type of method, we would just ask that you reach out to Veda or I and let us know that you might be interested in implementing this in your clinic so that we can workshop with you a little bit and make sure that that process is going to run smoothly. But through that process, really, we will provide you with education materials that you can use in your clinic, like a pre-test video that the patient can watch. It's about 10 minutes long. It covers really all of the essential elements of informed consent for genetic testing, explains why the test is being done, what the test might find, and how the results of that testing might be used. And then you can order the genetic test. And that is often easiest if you order it at the Yale DNA Diagnostic Testing Laboratory, just because the blood sample just sort of flows seamlessly from your clinic to the laboratory. The results are all integrated into Epic. The test order is in Epic, and that would be an order for an extended gene panel. And then importantly, with this sort of methodology of testing, if there's an insurance authorization that needs to be completed, sometimes that can be completed by the Yale DNA lab. Other times it needs to be completed by the ordering provider's office. So if you were to be interested in this model of care for your patients, just be aware that it does sometimes mean that you need to get involved into kind of that messy process of the insurance authorization for testing.
And I'll just interject because I meet with the lab fairly often, and the intent is to really have the prior auth come from the lab the vast majority of the time. Yes. And when you order this, they ask you these like extra questions that helps them be able to do it. So I wouldn't be discouraged from the concept of starting to broach this as we become more familiar with genetic testing.
Yep. And I think that the real key piece here is that, you know, we certainly want you to feel empowered to order genetic testing for your patients. But what we would ask is that, you know, you allow us to help you with that pre-education before the test through that video, and that you also consider simultaneously referring the patient to our program for a results disclosure appointment. So you will get a copy of the test report and can certainly discuss that with your patients. But if you refer to our program, then they will meet with a genetic counselor for a results disclosure visit that will last anywhere from 30 to 60 minutes, where the genetic counselor will go over the results of testing, take a 3-generation family history, make sure there wasn't anything missed that needs to be kind of reanalyzed through that test. And then you will get a nice summary note that includes medical management recommendations based on the outcome of the patient's test and their family history, sent back to you at the conclusion of that visit. I think Dr. Giri is going to talk a little bit about some other options that are available to you as well.
Yes, and so as Claire said, you know, we really are looking to partner with primary care colleagues to empower genetic testing in your own practice with point of care. And it's also recognized too that maybe in some of the busier clinics or in the, you know, the clinical arena, it can be hard sometimes to implement that point of care process. And so what we also have developed is, of course, our referral mechanism to our Smilow Cancer Genetics and Prevention Program. We've actually simplified that mechanism recently. So in this left-sided box, you can see that in Epic, you can just select the ambulatory referral to Smilow Cancer Genetics, and it auto-populates some of the information. So you don't have to click around and find as much as needed in the past. So you just select that and then indicate the clinical reason for referral. And there too, if you can be as specific as possible, that would be terrific, because what we're going to do when we receive the referral behind the scenes is triage that patient to either see one of our genetics coordinators in the Fast Track program, which is a new program that we've developed, an arm of our program, or to see a genetic counselor. And we developed the Fast Track program as a way to have rapid delivery of genetic assessment and testing. What we did was take the principles of point of care and move it under our program so that we're showing the pretest video, we're ordering the genetic testing through the Yale DNA laboratory. One of the new things that's coming forward, and this is mandated by our compliance and federal regulations, is that genetic test orders for internal providers will have to be signed by the referring doctor. But what we're trying to do is actually our team is working on systems to actually upload all of that information and just pend it for signature in Epic for the referring doctor. So it would be like an in-basket sign order kind of a thing. So we really didn't want that to be a barrier. And so hopefully this will work out very well and all will be in compliance. And then we go through the rest of the processes as would be necessary for results disclosure and the full information to be delivered back to the referring doctor for recommendations for the patient and their family members as appropriate as well. So these genetic coordinators are working very closely with the genetic counselors. So they review all of their cases with the genetic counselors. So it's actually really embedded within the expertise of the cancer genetics program. And then I'll turn it back over to the genetic counseling side of this program as well, to Claire.
Yeah, so within the genetic counselor arm, we really feel like the patients who are best served by a genetic counselor are those who have a complex personal or family history. Maybe we're not sure if they really fully meet guidelines. They need a formal risk assessment before we can sort of determine whether or not genetic testing is necessary. And there are some insurance companies that actually mandate genetic counseling be performed before genetic testing can be authorized to continue. So those are the patients that we feel like are best served by a genetic counselor. The genetic counselors meet with the patients for around 60 minutes. We take a full family history, do a risk assessment, and then order the genetic test, whether that goes to the Yale DNA lab or to an outside laboratory. Same compliance related test order signatures required by the referring provider here. In some cases, if the patient was referred by an external provider, not within the health system, the patient may meet quickly with an APRN or an MD just for medical management sign off and the test ordering. And then we will complete the insurance authorization. We will take care of the results disclosure, of course, with communication back to the referring provider with the results, the details of the results, and the medical management recommendations. So whether your patient sees someone through the Fast Track program, through genetic counseling, they really will receive all of this care. So we make sure the patient really understands why they're there and what they're there to do. Take a medical history. We review a 3-generation family history. We perform a risk assessment and a differential diagnosis, primarily in the counseling arm. Our genetics clinical coordinators don't have quite that level of training. We review hereditary cancer syndromes and different test options with the patient, make sure that they're providing informed consent for that test. We may discuss research opportunities that are available to them based on their personal or family history, then complete the tests coordination, the insurance authorization. We ensure that the patients are aware of any genetic discrimination that may be possible. This is particularly of concern for our young, unaffected population who maybe have not put into place things like life insurance, long-term care, disability insurance yet. And then, of course, we review the results with the patient, typically over the phone, although some patients like to come back and get those in person or through a telehealth visit. And then we complete that follow-up through sending the patient's written material that also goes to the referring clinician. So what you can expect after you place the referral, your patient's going to receive a secure link to complete an online family history questionnaire. They'll be called to schedule an appointment and they'll complete a brief intake over the phone. Their consultation will last anywhere from 30 to 60 minutes. And I think it's important when you're sort of talking about referring patients to meet with us to please make them aware that it is an appointment. It's not just the test, because sometimes patients come in saying, well, I don't know, I thought I was just here to get my blood drawn, and they're not really expecting to sit down and talk with anyone for a while. So it can be helpful to kind of set the stage for them that, that appointment will be 30 to 60 minutes, and then you'll get your blood drawn if you decide to have testing. We do review cases at a weekly case conference with our MDs, our APRN, to determine appropriate medical management for our patients. And then, like I mentioned, we disclose those results, and the patient and the referring provider receive written documentation of those recommendations. So if we go back to case 3, if you remember, this was a gentleman who had a strong family history, was Ashkenazi Jewish, and does actually have a BRCA2 pathogenic variant.
So what do we do? Or what did we do in some cases, as this is really retrospective? But what additional tests are necessary for a male with a BRCA2 history? Veda?
Yeah, absolutely. So again, so much more public awareness is needed about BRCA and application in males to think about this. And so for a male with the BRCA2 mutation, they are at risk for specific cancers, including male breast cancer, prostate cancer, and pancreatic cancer, as well as melanoma. So for the male breast cancer, the recommendation is to start clinical breast exams at age 35. And this can be performed, of course, by the primary care physician or a breast surgeon. And typically every 6 months, 6 to 12 months is really the recommendation for these individuals. So again, a recommendation that wouldn't otherwise have happened. Prostate cancer is a big cancer linked now with BRCA2 and rising in terms of the risk for prostate cancer. It's associated with aggressive disease, early onset disease. So in the NCCN guidelines, the recommendations are to start prostate cancer screening at age 40 for male BRCA2 carriers. There's lots of studies going on about how best to optimize that screening as well, but starting at age 40. And then we talked about pancreatic cancer screening already for the other case, but here to really consider if there's a family history, especially of pancreatic cancer, to refer to high-risk gastroenterology to discuss the risks and benefits of pancreatic cancer imaging and screening. But even still, like I said, at our institution, we tend to refer a little more liberally because we have that expertise and the CAPS-5 study recruitment as well going on. So it's a nice opportunity for individuals. So those are really like the key implications for the patient. And then it does bring in the importance of cascade testing for the blood relatives. This is also really important for men to consider the impact of this for male and female blood relatives.
Good. So we're into our question, answer, conversation, and discussion part of the evening. We just have 6 minutes left. So I'm going to look at Jill Banatowski, who asks, which patients with a new prostate cancer merit genetic testing?
Yes, great question. The prostate cancer genetic testing guidelines have significantly expanded. If you want to keep the top ones in mind, sort of the heavy hitters when thinking of genetic testing, it's those men that have metastatic prostate cancer, and then features of high-risk disease like advanced stage, T3 or higher. So basically extended to outside the prostate or to the lymph nodes. PSA that's been high at the time of diagnosis, over 20, Gleason score of 8 or higher. So those are some of the key criteria. Oftentimes, though, a lot of individuals, the majority of individuals are diagnosed with lower risk disease, and then family history becomes really important to think about. So going back to those family history criteria that we highlighted from the NCCN guidelines becomes important.
And I know one of the things that I'm familiar with by working on the care signature pathway for prostate cancer screening is there's a whole link to genetic testing and indications. And I think in general, all of the cancer screening pathways, they're still working on breast. The others are there, and more continue to be developed all the time. But a lot of times we've made a point of putting in a link to some of the genetic testing. So that's always a good source of information as well.
Absolutely. And if I can just say that it's great to have the primary care team here, because these individuals become survivors, many, many thousands. And so to go back and take that family history and see, could genetic testing have been done if it wasn't done, is a really important space in primary care.
Right, because there are additional cancers that develop when we follow people over essentially a lifetime in many cases. That's true.
Yes.
So if there are other questions, please enter them. I'm going to ask Claire about cost of genetic testing. So there was a period of time, maybe it's ended, maybe it hasn't, where a lot of the genetics consults would come back saying, we could test this, but we would have to get prior auth and your out-of-pocket cost would be this. And it turns out for $320, we can just have you order this test yourself and bring it back to us. Or maybe I'm paraphrasing that a little, but it was essentially a self-pay test that was a multi-gene cancer analysis that your group was recommending. And that out-of-pocket cost was somewhere in the $300 range. What are the cost implications for patients? And do you ever still recommend that where it comes back on a fax form rather than through the Yale lab?
Yeah, I mean, I think in most cases, if a patient makes their way to us and they are interested in testing, we are happy to help coordinate that for them, even if they're not particularly high risk. So if a patient meets NCCN criteria, they do in most cases have insurance coverage for their testing as well. But as you alluded to, the cost of genetic testing has come down significantly. So the out-of-pocket price to patients, really, we don't want to see patients pay more than $250, $300 towards a genetic test if they're paying out of pocket. It used to be that these were like $1,000 tests, but the competition in the market has driven the cost down, which is great for patients. So in most cases, even if a patient comes to me and they don't have really any risk, but they say, I really want this information, I'm happy to order it for you. You'll just have to pay for it out of pocket rather than going through insurance.
I see. So these were lower risk. I'm over referring to cancer genetics. I think it's such a valuable service.
What about lung cancer? That's my expertise, but there are several never smokers that have family histories. What's the latest with that?
Yeah, so unfortunately, the hereditary lung cancer is still in its infancy, I think, but it is actually an area of interest for me as well, Anne. So the data right now is really in the EGFR gene space. And so particularly for non-smokers who are pre-treatment, if they have an EGFR, particularly the T790M mutation, that would be a consideration for genetic testing.
Got it. I will send them your way. Any other questions? Okay, if you can advance the slide to the next one. If we can ask folks on the line to complete the survey at the end of today's event. Next month, we have lymphadenopathy and diagnoses with Dr. Alam, Dr. Isufi, and Dr. Montanari. And then previewing in December liver cancer with our faculty there. Please spread the word. Continue to access this via YouTube or Vumedi, but we certainly appreciate when you show up and of course your questions afterwards if you have any comments on the survey. Thanks so much for your feedback. This has really prompted us to do another year. We hope you all have a great evening. Thanks to our faculty tonight. Thank you so much. I learned so much. It's been fantastic.
I did too. I always learn so much from these. It's wonderful. Thank you, guys.
Pleasure to be here.